Every single night across this country, more than 37 million adults are showing their bodies the early warning signs of type 2 diabetes, and they have absolutely no idea. Not in a clinic, not during a checkup, not under fluorescent hospital lights, in their own beds, between the hours of 11 p.m. and 4 a.m. When the body is supposed to be resting, repairing, and resetting, it is instead screaming for help, quietly, persistently, through symptoms that almost every doctor in this country will look at, smile politely, and call normal aging. That is a lie. It is a dangerous, comfortable, convenient lie, and it needs to be shattered right now. Because what most people over the age of 50 are calling just getting older is, in a significant percentage of cases, the silent biochemical opening act of a disease that will eventually take their vision, their kidneys, their feet, and years of their life. The tragedy is not that diabetes is hard to detect. The tragedy is that the body announces it months, sometimes years in advance, through the night, and the medical system has been trained to ignore those announcements until the blood sugar number on a fasting lab finally crosses an arbitrary line on a piece of paper. The system makes money when you stay sick, not when you get better. There is no billing code for catching diabetes at 3 a.m. There is no insurance reimbursement for a 40-minute conversation about why someone is waking up at the same hour every night with their heart pounding and their mouth dry. So that conversation never happens, and the disease keeps growing. Before going any further, take 1 second to subscribe to Dr. Waterling and hit that like button. The channel is working toward 1,000 subscribers, and it is being built on one principle: telling people over 50 what their doctors do not have the time, the incentive, or in many cases, the permission to tell them. Every subscriber moves that mission forward. This is not a transaction. This is a movement of people who refuse to accept "it's just your age" as a medical opinion. Now, here is what 15 years of clinical practice has made painfully clear. Type 2 diabetes does not begin the morning a lab report says so. It begins 5, sometimes 10 years earlier in a phase called insulin resistance, where the body is still keeping blood sugar in the so-called normal range, but only by working harder and harder behind the scenes. During the day, that struggle is hidden. Food comes in, the pancreas pours out more insulin than it should have to, the muscles and the liver respond sluggishly, and the number on a daytime test still looks acceptable. But at night, the masks come off. The body cannot hide what is happening when there is no food, no movement, no distraction. And that is exactly when the warning signs appear. Here is the first one, and it is the one most often dismissed. Waking up between 2 a.m. and 4 a.m. Almost every night at roughly the same time, often with a dry mouth, a racing heart, or a feeling that something is wrong without being able to name it. Most people blame stress. Most doctors blame age, menopause, or lighter sleep in older adults. That explanation is incomplete to the point of being misleading. Let me explain exactly what is happening inside the body during those hours. Between 2 and 4 a.m., the liver performs a process called gluconeogenesis. In plain language, the liver is manufacturing glucose from scratch and releasing it into the bloodstream to keep the brain fed during the overnight fast. In a metabolically healthy person, this release is gentle, controlled, and matched by an equally gentle release of insulin from the pancreas. The blood sugar barely moves. The person sleeps through it. But in a person developing insulin resistance, the liver overproduces glucose, the pancreas overshoots insulin in response, and then the blood sugar drops too quickly. That drop triggers the adrenal glands to release cortisol and adrenaline. Those two hormones do exactly what they are designed to do. They wake the body up. They speed up the heart. They dry the mouth. They flood the system with alertness. And there the person lies at 3:14 in the morning, staring at the ceiling, convinced they just have insomnia. That is not insomnia. That is a blood sugar event. And it is happening because the system that controls glucose is already failing years before any fasting lab will catch it. The second nighttime sign almost everyone misses is excessive nighttime urination, and not the kind caused by a small bladder or an enlarged prostate. The kind where someone is getting up 2, 3, sometimes 4 times a night, and the volume each time is substantial. In medicine, this is called nocturnal polyuria. When blood glucose rises above roughly 180 milligrams per deciliter, the kidneys can no longer reabsorb all of the glucose that filters through them. The excess glucose spills into the urine, and glucose is osmotically active. That means it pulls water with it. The result is large volumes of urine produced during the night, dehydrating the body and disrupting sleep. People are told it is their bladder. In a substantial percentage of cases over the age of 50, the bladder is not the problem. The bladder is the messenger. The kidneys are dumping sugar, and no one is looking at the kidneys. The third sign is intense nighttime thirst. Not a casual sip of water at the bedside. The kind of thirst that wakes a person up, drives them to the kitchen, and is not satisfied by one glass. This is the direct consequence of the fluid loss just described. The body is dehydrating from the inside out because sugar is being lost through the urine. Yet the medical visit notes will say patient reports increased fluid intake at night, likely habitual. That is not habit. That is a body in osmotic distress. The fourth sign is nighttime leg cramps and restless legs, particularly in the calves, particularly in the second half of the night. Elevated blood sugar damages the small nerves and the small blood vessels that feed the peripheral muscles. This is the earliest stage of what will eventually be called diabetic neuropathy. Long before there is numbness, tingling, or burning in the feet during the day, there are cramps and twitches in the legs at night. Most patients have been told this is a magnesium deficiency, a potassium issue, or simply what happens when you get older. Sometimes magnesium helps temporarily, but it does not fix the underlying problem because the underlying problem is not the magnesium. It is the sugar damaging the small fibers in the legs. The fifth sign is night sweats, particularly upper body sweats, particularly in people who are not in menopause or who finished menopause many years ago. This is the same cortisol and adrenaline surge described earlier, expressing itself through the sympathetic nervous system. The body is reacting to a metabolic emergency in the middle of the night, and one of the visible signs is a damp pillowcase and a soaked nightshirt by 3 a.m. And the sixth sign, the one that is perhaps the most overlooked, is intense hunger, or specifically intense cravings for sugar or refined carbohydrates within 30 to 60 minutes of waking. This is not a personality flaw. This is not weak willpower. This is a body that spent the night riding a glucose roller coaster and is now demanding fast fuel to recover. People are told to eat more protein, drink more water, try intermittent fasting. None of that addresses the underlying instability driving the craving in the first place. So here's the question. With 6 clear, measurable, physiologically explainable warning signs occurring every single night in tens of millions of people, why is this not being caught earlier? Why are people walking into clinics, describing some or all of these symptoms, and walking back out with a prescription for a sleep aid, a recommendation to drink less water in the evening, and the words, "It's probably just your age"? The answer is uncomfortable, but it is simple. The standard fasting glucose test, the one almost everyone over 50 has done once a year, measures blood sugar at one single moment in the morning, usually after the body has spent the previous 3 hours suppressing glucose release in preparation for the day. By the time someone sits down in a lab chair at 8 a.m., the body has already cleaned up the mess from the night before. The number looks fine. The doctor looks at the number, not the patient, and says everything is normal. The patient goes home, wakes up at 3 a.m. that very night with a pounding heart, and assumes the doctor must be right. The doctor is not right. The doctor is looking at the wrong window of time. There is a test called hemoglobin A1C, which measures average blood sugar over the previous 3 months, and there is a more advanced approach using a continuous glucose monitor for 2 weeks. Both of these will catch insulin resistance years earlier than fasting glucose. Yet most primary care visits do not include A1C testing unless the fasting glucose is already abnormal. By the time A1C is finally ordered, the disease has often been brewing for half a decade. Here is where it gets critical. Because the same body that is sending these signals at night is also responding beautifully and quickly to the right interventions. And those interventions cost almost nothing. They do not require a prescription. They do not require expensive supplements. They require understanding and discipline, and they can begin tonight. Now, what should actually be done about this? Here is the complete, clinically organized protocol, step by step, evening, night, and morning. The evening protocol begins with dinner timing. Dinner needs to end at least 3 hours before bedtime. Not 2, 3. The reason is that any food consumed within 3 hours of lying down will still be triggering insulin release during the early part of sleep, which sets up the rebound described earlier. For someone going to bed at 10 p.m., dinner should be finished by 7. For someone going to bed at 11, dinner should be finished by 8. This single change alone has been shown in multiple clinical observations to reduce nighttime awakenings within 7 to 10 days. The composition of that dinner matters enormously. The plate should be built around roughly 150 to 200 grams of non-starchy vegetables, which is about 2 cups loosely packed, combined with 100 to 150 grams of protein, which is about the size of a deck of cards, and a small portion of healthy fat, such as 1 tablespoon of olive oil or a quarter of an avocado. Refined carbohydrates, white bread, white rice, pasta, pastries, and sugary sauces must be removed from the evening meal entirely. Not reduced? Removed. Carbohydrates at dinner are the single largest driver of nocturnal hypoglycemic rebound in people with early insulin resistance. 30 minutes after dinner, a 10-minute walk, not a workout. A walk. Slow conversational pace around the block or around the living room if the weather is bad. 10 minutes of light walking after the evening meal reduces post-meal blood sugar peaks by an average of 12 to 22% according to research published in peer-reviewed metabolic journals. That walk alone may be the single highest leveraged diabetes prevention behavior in existence, and it costs nothing. 1 hour before bed, prepare a simple drink. Take 250 milliliters of warm water, about 1 cup, add 1 tablespoon of apple cider vinegar with the mother, and add a small pinch of cinnamon, about 1/4 teaspoon. Stir and drink slowly over 5 to 10 minutes. The acetic acid in the vinegar slows gastric emptying and improves overnight insulin sensitivity by roughly 19 to 34% in studies of adults with prediabetes. The cinnamon contributes a modest additional effect on fasting glucose. This drink is not magic. It is mechanism. It works because the chemistry is real. A caution here. Anyone currently taking metformin, sulfonylureas, insulin, or any other medication that lowers blood sugar must not begin this protocol without speaking to their prescribing physician. The combination of these dietary changes with glucose-lowering medications can cause blood sugar to drop too low. Nutrition works alongside medical treatment, not instead of it. The conversation with the prescriber is non-negotiable. 30 minutes before bed, the bedroom needs to be prepared. The room temperature should be between 65 and 68 degrees Fahrenheit, or roughly 18 to 20 degrees Celsius. Cooler temperatures improve deep sleep, and deep sleep is when insulin sensitivity is restored. All screens off. All overhead lights off. 1 small warm lamp acceptable. This is not wellness theater. Light exposure after 9 p.m. measurably raises overnight cortisol, which measurably worsens nighttime glucose control. Now the in-bed portion of the protocol, lying flat on the back, perform 5 cycles of slow diaphragmatic breathing. Place 1 hand on the chest and 1 hand on the abdomen. Breathe in slowly through the nose for a count of 4, allowing the lower hand to rise while the upper hand stays still. Hold for a count of 4. Exhale through slightly pursed lips for a count of 6. Repeat 5 times. This activates the parasympathetic nervous system, lowers cortisol, and creates the metabolic environment in which the liver behaves itself during the night. The morning protocol is just as specific. Upon waking, do not immediately reach for coffee. The first thing the body needs is water. 300 to 500 milliliters, about 2 cups, room temperature, sip slowly over 5 minutes. The body just spent 8 hours dehydrating through respiration and urine. Rehydrating first stabilizes the morning cortisol curve. Then before any food, 10 minutes of movement, not exercise, movement. Slow walking, gentle stretching, or 20 bodyweight squats performed slowly with the back against a wall. The purpose is to wake up the skeletal muscles and prime the glucose transporters, called GLUT4 receptors, that pull sugar out of the bloodstream and into the muscle cells. Movement before breakfast meaningfully improves the body's handling of the first meal. Breakfast itself needs to contain at least 25 to 30 grams of protein. That is roughly 3 eggs, or a cup of plain Greek yogurt with a tablespoon of chia seeds, or a small portion of leftover chicken or fish from the night before. Carbohydrates at breakfast should be slow, fibrous, and modest. Half a cup of whole rolled oats cooked in water with a sprinkle of cinnamon is appropriate. A bowl of sugary cereal, a bagel with jam, or a glass of orange juice will sabotage everything done the previous night. This brings us to a story that captures all of this in a single human example. There was a patient, Margaret, age 64, retired bookkeeper. She came in with a specific complaint. She was waking up at 3:15 every morning, almost on the dot, with a pounding heart and a dry mouth. She had been told by 2 previous physicians that this was anxiety related to retirement, that she should consider a low-dose sleep aid, and that her fasting glucose was 98, which was normal. Her A1C had never been measured. She had gained 12 pounds over 3 years that she could not explain. Her energy in the afternoons was crashing. Her vision was getting blurry by evening. She had also developed nighttime leg cramps that her previous doctor attributed to potassium. Her A1C was ordered. It came back at 6.2%, squarely in the pre-diabetic range. A continuous glucose monitor was placed for 2 weeks. The data showed exactly what was suspected. Every night between 2 and 4 a.m., her blood sugar was swinging from 140 down to 62, then rebounding back up. Her daytime numbers looked acceptable. Her nighttime numbers were chaos. She implemented the protocol exactly as described. Dinner finished by 7 p.m. Refined carbohydrates removed from the evening meal. 10-minute post-dinner walk. The vinegar and cinnamon drink. Cooler bedroom? Breathing practice. Protein-forward breakfast. Within 9 days, the 3 a.m. waking stopped. Within 3 weeks, the leg cramps were gone. Within 3 months, her A1C was 5.6%, comfortably out of the pre-diabetic range. She lost 9 pounds without trying. She did not take a single prescription medication. That is not a miracle. That is what happens when the body is finally given the conditions it needs to do its own work. Now, before closing, the warning signs that do not belong in this protocol and require immediate medical evaluation. If someone experiences sudden extreme thirst combined with rapid weight loss over a few weeks, that is not insulin resistance. That can be the onset of type 1 diabetes or advanced type 2 and requires evaluation within days, not months. If there is fruity smelling breath, deep rapid breathing, confusion, or vomiting, that is a medical emergency called diabetic ketoacidosis, and that requires calling emergency services immediately. If there is sudden vision loss, one-sided weakness, slurred speech, or chest pain, those are vascular emergencies and require immediate transport to an emergency department. Do not drive. Do not wait. Call for help. For anyone with established kidney disease, heart failure, or who is on multiple medications, the protocol described today should be discussed with the treating physician before beginning. The interventions are gentle, but the body's response can be significant, and medication doses sometimes need to be adjusted as metabolic health improves. Here is the truth that the system will not hand out at a 12-minute office visit. The body is not broken. It is not aging into disease on a fixed schedule. It is sending signals every single night in language that is precise, consistent, and entirely readable once someone knows how to read it. A 3 a.m. wake up is data. A dry mouth at night is data. A leg cramp at 4 a.m. is data. Nighttime sweats and morning sugar cravings are data. None of these are normal aging. All of them are early reversible warnings. The window for reversal is real, and it is wide open for most people in the pre-diabetic range. Once full type 2 diabetes is established, the window narrows considerably. 5 to 10 years of insulin resistance can often be undone in 3 to 6 months of consistent practice. 5 to 10 years of established diabetes is a much harder road. The decision of which road to walk is being made tonight and every night by what gets eaten, when it gets eaten, and how the body is prepared for sleep. One last question before closing. How old are you? Write it in the comments below. The age distribution of this audience directly shapes which conditions get covered in future videos, and right now, the focus is on building content that meets people exactly where they are. Whether 52, 64, 71, or 83, every number in the comments helps shape what comes next. If this video helped clarify something that has been dismissed for years, share it with someone who deserves to hear it. A spouse who keeps waking up at 3 a.m. A parent who has been told it is just their age. A friend who has been quietly gaining weight and crashing in the afternoons. They may have just been handed a real chance to catch something early, while it is still fully reversible. And subscribe to Dr. Waterling. The channel exists for one reason: to say out loud what the system has decided is not worth the appointment time. The next video will go deeper into the specific foods that stabilize overnight blood sugar and the 3 morning habits that quietly destroy insulin sensitivity in people over 50. None of it will be covered at the next checkup. All of it will be covered here. The body has been talking every night. It is time to start listening.